Key learning points. We will consider what is meant by the term patient safety. Then we will look at safe, affordable anaesthesia and surgical care and how it has recently become a global health priority. Then we'll consider access to safe anaesthesia care worldwide and why between different countries there are differing rates of anaesthesia-related mortality. Then we will look at the history of safety standards within anaesthesia. We will look at examples of standards produced by the World Health Organization and the World Federation of Societies of Anaesthesiologists before looking at our own Orbis safety standards. Then finally we will finish by considering not only safe care but also quality of care. Ensuring affordable universal health coverage will provide healthy people that will benefit their family, their community and their country. In recent decades, global healthcare has focused on infectious disease, maternal and child health, public health campaigns and non-communicable diseases. However, there remains a huge surgical burden that is unmet in many countries. Thanks to two key documents published in 2015, this has become a more prominent global health issue. The first of these was the Lancet Commission for Global Surgery, and the second was Disease Control Priorities 3rd edition Volume 1 Essential Surgery, published by the World Bank. Both of these important documents can be found in the resources section to this module. The key findings from these two documents were that 5 billion people do not have access to safe, affordable surgical and anaesthetic care, the vast majority of whom live in low and middle income countries. Of the 313 million surgeries performed each year, only a tiny minority are performed in low and middle income countries, and often there is a high associated mortality rate. An estimated 143 million additional essential surgical procedures are needed each year and to be provided at first level district hospitals. Strengthening emergency and essential surgical anaesthesia capacity, particularly at these first level hospitals, is a highly cost efficient solution to the global burden of disease and is likely to add some 2% to a country's gross domestic product. Welcome to the e-learning module, Infection Control and the Anaesthetist. This forms part of Section 1, Principles of Safe Anaesthetic Practice. The key learning points for this module are as follows. Firstly, to address every anaesthesia provider's responsibility for infection control. Then to discuss the meaning of standard precautions and the role of hand hygiene. We will cover occupational health and immunisations, personal protective equipment with particular attention to special considerations during the COVID-19 pandemic, cleaning and decontamination of both the anaesthetic environment and any reusable airway equipment. Appropriate procedures will be considered. We will review safe disposal of clinical waste, the safe use of sharps and medication safety. Finally, we will discuss antimicrobial stewardship. You can find additional information on infection control and prevention in the recently updated Association of Anaesthetists of Great Britain and Ireland guidelines in the link in the Resources tab to this e-learning module. Healthcare-associated infections are the most frequent adverse event in healthcare worldwide. The WHO statistics, detailed in the Resources tab to this module, estimate that the rate is about 10% in low and middle income countries and approximately 7% in high income countries. Bladder infections are commonest in the high income setting, whereas wound infections account for up to 2/3 of infections in low and middle income countries. Also, chest infections and indwelling device infections are several times more prevalent in the less well-resourced intensive care unit. These healthcare-associated infections place an additional strain on healthcare systems, with increased morbidity and mortality. A prolonged length of stay may be required, with financial implications for the hospital, damage to reputation, and risk of litigation. Hospitals have a responsibility to reduce these infections, and in many countries this extends to a legal responsibility. Hospitals should strive to put in place local policies and procedures for infection prevention and control, and these should be regularly monitored. As healthcare professionals, it is our personal responsibility to ensure the highest standards of infection control for our patients. In the UK, it is recommended that every anaesthetic department have a lead for infection prevention who can work with infection control teams to ensure standards relevant to anaesthetic practice are maintained. Standard precautions can be defined as the minimum required standards for the prevention of a healthcare associated infection. These measures must be applied in any healthcare encounter. They include hand hygiene, use of personal protective equipment, cough etiquette, sharp safety, safe injection practices, safe handling of waste and soiled linen, and decontamination of the environment and any, for example, reusable airway equipment. In the presence of an infectious disease, these measures can be supplemented with additional infection control measures based on the transmission mechanism of the pathogen, whether that be by contact, droplet, or airborne. Hand hygiene featured as part of the World Health Organization's first Global Patient Safety Challenge, Clean Care is Safer Care. They highlighted the hands as the main source of transmission of infection, and so hand hygiene is the single most important measure to prevent healthcare-associated infection. All healthcare workers should know how and when to perform hand hygiene. The WHO describes 5 moments of hand hygiene. We should all clean our hands before and after touching a patient, and before any aseptic procedure, after any potential exposure to body fluids, and also after touching items in the patient's environment. For good hand hygiene, it's also important that we look after our hands. We should cover any cuts with waterproof dressings, Use moisturising cream at least once daily and never put gloves on before our hands have completely dried. Hands must be washed with soap and water at the beginning of the working day and when they are visibly soiled, for as long as it takes to sing Happy Birthday twice is the World Health Organization's recommendation. Alcohol rub is the preferred means for cleaning our hands at other times. It's better tolerated by our skin and often more efficient, but we should also remember that alcohol rub is not effective against Clostridium species and some enteric pathogens such as norovirus. When we use alcohol rub to clean our hands, we need a formulation that is at least 70% alcohol, and we should aim for 20 to 30 seconds of hand washing. Around 3 ml is needed per use. The WHO has guidance on the recommended technique for cleaning hands with alcohol gel and for washing with soap and water. A link to this document can be found in the Resources tab here. We must be mindful of the areas frequently missed during hand washing, particularly the back of the thumb and fingertips. If we are scrubbing prior to an invasive procedure, additional measures need to be taken for hand washing, including cleaning under the nails and the use of sanitizer solutions such as 4% chlorhexidine or 10% povidone iodine. We have a duty to protect our patients and fellow workers from any risks that may be posed by our own health. This would include any infectious diseases which could be transmitted within the healthcare environment. Communicable diseases should be discussed with occupational health or your line manager. In particular, you should not attend work if you have any new diarrhea or vomiting and should wait until 48 hours after symptoms have resolved before resuming your duties. In the prevention of transmission of respiratory diseases, it is important to cover your nose and mouth when sneezing or coughing. If you don't have a tissue, you should cough into your antecubital fossa. If a tissue is used, you should dispose of it straight away. You should clean your hands after you cough, sneeze or blow your nose. National vaccination programs are another important way to reduce infection, and healthcare workers should engage with these programs. Every country will have its own national vaccination program, which may include vaccines such as measles, mumps and rubella, polio and tuberculosis. Healthcare workers may be eligible for additional vaccines such as hepatitis B, influenza and pneumococcal. Local and national policy advice on personal protective equipment in the operating department should always be followed. This is likely to include the following. Clean scrubs should be worn by all staff. Personnel should be discouraged from moving in and out of the operating department unnecessarily, except in an emergency situation. Scrubs should be washed in the hospital laundry where possible, but if it is necessary to wash at home, then this should be done at 60 degrees or hotter. Where splashes from body fluid are anticipated, full-body fluid-resistant gowns provide the best protection. Designated footwear to be worn in the operating department, and a procedure in place for cleaning these shoes. Overshoes are not recommended and can lead to contamination of the hands when they are taken on and off. If cloth hats are used, they should be washed daily. Gloves should be worn for any patient contact where there is a risk of body fluid exposure, but they must be used correctly. Gloves are single-use items and should be put on immediately before an episode of patient care and removed straight away afterwards. Hands should be washed following their disposal. For an invasive sterile procedure, the minimum PPE is surgical face mask and sterile gloves and gown. The need for eye protection should be risk assessed. With regard to the general use of face masks in the operating room, there is some controversy. Surgical face masks should be worn for all implant procedures, but their role in preventing post-operative wound infection when worn by non-scrubbed staff in other cases is uncertain. Most hospitals will have their own policies on surgical face masks, but when worn they should be single-use and kept over the nose and mouth throughout the case. Severe acute respiratory syndrome coronavirus 2, or SARS-CoV-2, is a novel coronavirus which first emerged in China in 2019 and rapidly spread across the world. It is the infectious agent for the disease known as COVID-19. The incubation period is 1 to 14 days with a median of 5 days. Symptoms are on a broad spectrum from the asymptomatic, common in childhood, through to fever, cough, breathlessness and muscle aches, and onto multiple organ failure in the most severely affected. Infection control measures for COVID-19 rely upon standard precautions plus additional measures based on the modes of transmission. The most common route of transmission is by environmental contact. Airborne spread via large droplets, 5 to 10 microns, over short distances of less than 2 meters. The droplets spread directly from an infected person's respiratory tract onto a mucosal surface of another individual. Aerosol-based transmission is the spread of small particles less than 5 microns, which penetrate our respiratory system down to the alveolar level and occurs when we perform aerosol-generating procedures such as intubation. Local and national bodies have released guidance on the recommended levels of personal protective equipment to be worn in different hospital settings. A link to one such guidance document can be found in the Resources tab to this section. In addition to PPE, other aspects of infection control are vital in preventing the spread of COVID-19 within healthcare facilities. These include at least twice daily disinfection of patient areas with minimum 1,000 parts per million chlorine solution and decontamination of reusable equipment. COVID-19 can survive for up to 72 hours on plastic and 48 hours on stainless steel. All waste should be treated as infectious clinical waste and disposed of appropriately. Linen should also be treated as infectious and handled only with gloves and apron, bagged and put directly into the linen receptacle. Ideally, patients should be managed in a negative pressure room if one is available, otherwise standard single rooms should be used, or infected patients cohorted together on a ward. Organisations can take measures to prepare for COVID-19 and to help prevent the introduction of infection into the hospital and to limit the spread of infection. Early recognition and triage of cases allow patients to be managed appropriately. Healthcare providers have a duty to educate staff on infection control measures and to provide appropriate personal protective equipment. Visitor access to the hospital should be restricted. For example, consider limiting visitors only to those patients receiving end-of-life care. Staff should receive clear information on the symptoms of COVID-19 and instructions not to attend work if they are symptomatic. Individual hospitals may have policies in place to test staff and facilitate return to work. Within the hospital environment, social distancing should be maintained, particularly in the communal areas such as changing rooms and dining areas. Consideration should be taken to dividing staff to work in either COVID or non-COVID environments to reduce transmission within the hospital. Some staff may be at higher risk of developing a severe illness if infected with COVID-19, for example, pregnant women or those with multiple comorbidities. Staff should receive a risk assessment and consideration be given to redeploying high-risk staff away from direct care of COVID-19 patients. Hospital managers and senior clinicians should take steps to plan for a surge of COVID-19 patients and how this would be managed in their facility. Aerosol generating procedures present the highest risk for disease transmission. These procedures include tracheal intubation and extubation, tracheostomy, tracheal suctioning, manual ventilation, non-invasive ventilation, and high-flow nasal oxygenation, as well as some surgical procedures that utilize high-speed drilling or suctioning of the respiratory tract and mouth. Chest compressions as part of resuscitation are a controversial area, some considering them as an AGP, but others holding an opposing view. Aerosol generating procedures should only be performed on COVID-19 patients when absolutely necessary, and ideally should be undertaken in a single room with the doors closed. Only the minimum staff required should be present in the room. The use of checklists and cognitive aids is helpful in preparing for AGPs. The Royal College of Anaesthetists and Faculty of Intensive Care Medicine have compiled a wealth of information, guidance and resources on COVID-19, and a link to this website can be found in the resources section of this module. The World Federation of Societies of Anaesthesiologists also has a site specifically aimed at anaesthesia providers working in low resource settings. Again, a link to this can be found in our resources. UK guidance on the recommended PPE for aerosol generating procedures include fluid repellent gown, full face shield or visor, double gloves and an FFP3 mask which should be fit tested. FFP3 masks, when fitted correctly, filter 99% of airborne particles. If none are available, FFP2 or N95 masks can be used, filtering 94 and 95% of particles respectively. Care should be taken when donning and in particular when doffing PPE, as this is the most common time to self-contaminate. It is vital to have a buddy to guide you and watch you as you don and doff, as you take on and take off your PPE. It's important to understand the definitions around decontamination processes. Decontamination comprises the two-step process of initial cleaning followed by either disinfection or sterilisation. Cleaning is the vital first step in the decontamination process and relates to the removal of visible foreign material using water and detergent. Organic material should not be allowed to dry before cleaning takes place. Low-level disinfection utilises disinfection